We're officially recording. Okay, so everybody noticed that was going to be watching the recordings. I did get them uploaded to Google Drive. Anyone have a problem accessing those or seeing them? Everything's good? Or those of you who are in here didn't watch them? Okay, so any questions, comments, concerns from anybody over yesterday's content before we jump in? Has anybody started the quizzes or anything like that? Okay.
So medical control, you have a medical director.
Correct.
So the director is like part of the control.
Sometimes. So the director in med control can be different doctors, if you will. So the medical director is the one who sets up all the protocols. They're the one that oversees all of the employees. You're working under their license for that particular agency. You can either call them if you have their number. So like Dr. Kumar and Dr. Robinson are our medical directors for Grady EMS. I can call them directly and say, hey, this is what's going on. Can I get some orders, outside of protocol? Either they can give it to me, or if I'm transporting my patient to say Grady, I can call Grady ER and say, hey, I need an attending physician, which is like the head doctor of the ER, to say I need some orders. That can be medical control. And because they have an MD license, even though they're not my medical director, they can give me, offline orders. As long as I document who I talk to, I can get permission to act outside of my protocol if I talk to the attending physician. But it has to be from the hospital you're taking the patient to. Like I can't call Grady and be like, hey, I need to talk to an attending physician to get some orders, and then take the patient to like Piedmont, because that doctor at Piedmont has no idea what the orders, it's a different doctor type thing. So it's got to be at the same facility. Yes, ma'am.
I started the quizzes and there was some question that was like, can I pull it up from my end still?
Ooh, maybe.
Go back on it.
Yeah, you can't. I don't think you're going to be able to pull it up on your end until it times out at the end of this module.
Okay, I'll just
Okay. Anybody else? Everybody else good? Y'all good over there? Okay. All right. So guys, I know we ran over a little bit yesterday. We're going to tack on chapter 4 this morning. I don't need 4 hours to talk about MedTerm. That's going to be a fairly short chapter because it's literally just going to be memorization on y'all's end. So we'll cover chapter 4, we'll jump into MedTerm, and then we'll get into human body. That's going to take a little bit of time because it's a lot of information. Okay. So everybody good before we get going?
Instructor A.
Yes.
Logan did not get the Zoom email.
Okie dokie. Hold on. All right. Tell him I just sent it over. All right. So chapter 4, guys, we talked about a little bit of some of the content that's going to be in this chapter yesterday, just about communicating with your patients, the importance of documenting. We'll go into a little bit further detail today. So communication, believe it or not, we have to go over how you guys are going to be talking to and speaking to your patients, because some people aren't very aware of those kind of social boundaries or what's appropriate. So understand that with communication in general, especially with these patients and their family members and bystanders, it's both verbal and nonverbal, right? All right, so what are some different things that go into your verbal communication?
Your tone of voice.
Your tone of voice, that's a big one, right? What else?
Asking the right questions.
Okay, what was that?
Asking the right questions.
Okay, so making sure that you're being specific, asking those questions that the patient can understand them, right? Because guys, once we jump into MedTerm, you're going to know a lot of terminology and a lot of words that, a typical lay person who has no medical knowledge is going to have zero clue what they mean. All right. So make sure you're using a vocabulary that's understandable to the patient. All right. What else?
Also have patience, because some people may take a moment to answer your questions, or they may need clarification on what it is you're asking specifically.
Absolutely. Understand, because guys, these patients, they don't know what the textbook answer is supposed to be to your questions, right? They don't have an EMT course under their belt. They don't know, or they may or may not know about human body, anatomy and physiology. They might not be able to answer your question exactly how you need to hear it to diagnose them, right? So you might have to rephrase a certain question, use different words until the patient can really understand or convey exactly what they're feeling. All right, what else? What about your volume, right? Making sure you're not yelling at the patient, you're not mumbling, making sure that the pace, you're not talking too fast is important. So remember a lot of the different things, especially guys, that tone of voice is everything. I kind of told a story about one of the partners I worked with yesterday who I've had to call APD on scene because she got into some altercations with patients that shouldn't have started. I could say one thing, I could have a phrase come out of my mouth. After I told that to the patient would be like super cool with me. They would be cooperative with me, but she would say the exact same words, but her tone of voice would make it where the patient wanted to punch her in the face. So that's just another thing. Y'all need to have some self-reflection through this course because sometimes, you know, people have what we call a resting, bitch face. All right, that goes into that nonverbal. You might not understand or might not realize that you're like giving off some not so great vibes by your body language. So we'll have some self-realization when it comes to communicating with people. You might have like maybe an attitude or a tone of voice that's not construed as pleasant, but it's not, you're not meaning to portray that, right? So just make sure you're catching your tone and all of that stuff. So again, nonverbal. What does that mean?
Professor A.
Language. Okay, so everything that you don't say out of your mouth. What are some things that you might have with your body language that might not give off the right vibes? Your posture. Guys, that's a big one. I normally just stand like this, right? But if somebody who doesn't know me and know my intentions, the first time I'm meeting them, if they're having a medical emergency or they're really bad hurt, if I come on scene, I'm standing there like this talking to them, what does it look like? I don't care. I don't want to be here, right? So again, be conscious of the way that you stand. Make sure, again, we are not coming off as intimidating or is that we're lacking compassion with these patients. All right, what else? This is going to be a big one. Your facial expression. All right, guys, I had to learn how to control my eyebrows because a patient would tell me a story and I knew that's absolutely not what happened. And I wouldn't say, okay, I don't believe you or you're full of it, but I would just be like, okay. So just make sure you're realizing your facial expressions. You got, like we said before yesterday, you got to develop a pretty good poker face. So if they are just telling you the most just asinine story and you don't believe it, you can't really portray that it's coming off in a judgmental kind of affect, right? You can ask them questions. So wait, this is what happened, or this is how you feel, or, you know, kind of clarifying, but just make sure that you're not coming across as, yeah, right, or you don't care, or you're judging that patient. Because guys, we've got to develop what we call rapport with these patients. What does that mean?
You have to let them know that you're somebody that they can trust while you're on the scene.
Trusting relationship. Just making that small talk, making that, you know, that small relationship with these patients will take you millions of miles. All right, because if you know somebody and you trust them and you feel like they have good intentions, what are you more likely to share? Everything. Information, all right? Maybe the truth, okay? Especially when it comes to a couple of different subject matters we're going to cover in this chapter, but you've got to let that patient know, it shouldn't really be false that you're letting them know, hey, I care about what's going on and I really want to help you, because that really should be your intentions if you're getting in this field and being on that call, right? But we all know we have bad days. We get stressed out. We get fed up with some stuff. But you should still let your patient know that, hey, I actually care about what's going on. How can I help you? Let's get this settled. Let's get it fixed. All right. They should be able to perceive that from you from the second you walk into the room. All right. What's some other nonverbal stuff that can kind of throw a patient off? Eye contact is a big one, right? We want to make sure that we're looking the patient in the eye an appropriate amount, right? We don't want to have that awkward like eye contact and you never break the eye contact and it's just really weird and it gets kind of creepy. Because that comes out as a little bit weird and awkward, but also that might be offensive to some people, right? But we don't want to be looking at the ground, fumbling through our jump bag, looking at our equipment and not ever making eye contact with the patient, because what does that say? Again, I don't care. I might not believe you. I might not care that, you're hurt or, this is just another call for me. Make sure you make that eye contact when you walk in the room. Okay. But break it at appropriate times. All right. Also too, when you're coming in their living room or whatever scene we're on, wherever they are, make sure you're not just coming in here like kicking open the door, dropping your jump bag, dropping your equipment, and just be like, why are we here? What's going on? Type thing. So there's a lot of different things that you might not think about when it comes to this nonverbal communication, or you might not realize about yourself. But if you start getting those vibes from your patient, remember you're getting what you're giving. So you might need to take a step back and be like, oh yeah, I am standing like this. It does kind of look, either intimidating or just way too nonchalant. So again, there'll be a lot of self-realization about your communication throughout this experience, but know that it does go a long way.
And Professor A,
Yes.
before we move forward, back on the verbal communication portion, and this is just because I've dealt with this when it comes to having to call EMS for my dad as a kidney patient.
Mm-hmm.
A lot of them that I've dealt with personally, and I know they don't all do this, is that there's sometimes a failure to actively listen.
Yes.
So there are times that we'll tell them something on the dispatch, and then we'll also tell the EMT the same thing, but then they'll still come in the door still asking the same question that we just gave them the answer to. And that part also gets frustrating too.
So yeah, some of that, it might not be that they're not listening, because there is a lot of information that gets lost in translation. Dispatch is great. They give you a ton of information, but the information they're giving you is only as good as the caller is, relaying. I'm not saying that you didn't relay the correct information when you talk to them, but if the caller's not giving appropriate information, or, is leaving some information out, we do still have to come on scene and confirm the information we got from dispatch, because it's like, I don't want to put my patient diagnosis and treatment, all of that stock in something that somebody else said that I didn't confirm myself. But yes, if we do arrive on scene and we're asking these questions to the patient, let's make sure you're listening, right? If you ask them, hey, what kind of medical history do you have? And then they reply with their medical history, and you just kind of let it go in one ear and out the other, and you're having to ask them that same thing like 3 or 5 minutes later, how does that come across? You don't care, you're not listening. So we do want to confirm all the information when we get on scene, but when you're actually getting that response from the patient, we do want to make sure we're registering that information. Okay. Talk about that. Oops, I started talking about. All right, guys, so this is just a little diagram that gives you a little more information if you weren't already aware that there's a lot of things that go into communicating to somebody, the things that we say, the body language we use, what they decipher, how they interpret what we say, and how they communicate back. So again, this is just a diagram that shows you the official, I think it's the Shannon-Weaver communication model. Guys, you will be aware when you're having a face-to-face conversation if your patient's not understanding what you're asking, right? They might have the eyebrows like, what does that mean? Or when they're giving you the answers, it might not be exactly what you intended. So we just learned to rephrase our questions. All right, so that's pretty much what goes into that. If you're not kind of on the same page with what the information is needed, then try to rephrase the questions, try to use different body language. Hey, try to use for charades, like point to body areas, like whatever you need to do to get that information across.
I'm sorry, can you hear me?
You what?
Can you hear me?
Yes.
Okay.
So did you not join in yesterday?
Disregard, it keeps freezing, so never mind.
Okay. Just have your mic muted. Unless you have a question, you can unmute your mic just so there's not any kind of background or, echo when I talk. All right. So again, guys, these are some things that go into consideration when it comes to communicating with our patient. All right, age, how is that going to matter? If they're a kid, right? I can't really go up to my 3-year-old and be like, well, hello, sir, how you doing today? Can you tell me your name? Can you tell me what day it is? Do you know what happened? Why am I here? Can you tell me your medical information? Like, that doesn't work. If you've never been around kids, now you know that that's not the way we communicate with kids, right? Also too, if the patient is a geriatric patient, we might need to consider what? Possibly some dementia, some short-term memory loss, some Alzheimer's. That's going to mean that their baseline mental status, where they stand normally, might be altered, and that might be normal for them. And they might not be able to interpret exactly what we're saying or know their medical background type thing, okay? Again, body language, culture, how does this come into play?
Question.
Okay, so maybe language. We might have a language barrier, right? That's a big deal. Guys, we're a major, major melting pot in Atlanta, all right? We have several different areas of the city, one in particular that is very Russian-based, all right? We have, Hispanic, we have Asian, we have all sorts of cultures and languages in the city of Atlanta. Grady has an amazing tool called the language line. All right, so if you get on scene and there's a language barrier, typically dispatch will communicate this to you before you get on scene. But you can call up this number, it's a recorded line, and we have people who are fluent in like 30, 40 languages, where you can say, hey, I need someone who speaks this particular language. They'll get them on the phone and you'll just play relay back and forth. Maybe now just put it on speaker so they're not touching your phone, right? But you'll say, hey, I need you to ask the patient this. And you tell them whatever you need to know. And they'll say, okay, hand the phone to the patient. And the patient, hears the question. They respond back to the interpreter. And then the interpreter says, okay, this was their response type thing. So it's really, really cool. Once you become an employee, it's just a phone number you can put in your phone. You can call them up and utilize that. So we have that communication barrier brought down. Correct. 24/7. All right. How else can culture play into it? So kind of going on what you said, Sean.
Some cultures might consider something to be like rude or offensive.
Right. All right, guys, different cultures, like the eye contact thing. There are some cultures who, if you walk in the room and you make direct eye contact, they consider that offensive. All right. So again, we're going to have the same initial approach to every single patient. We're going to come in, we're going to make the eye contact, we're going to introduce ourselves, and we're going to talk to them like a normal person, right? Based on their response, we might need to take a step back and alter our communication methods. All right, so going into tying in culture and gender. All right, there are some cultures who it is inappropriate if the patient is female to have a male patient care provider. All right, even if it's nothing invasive, just simply putting hands on that female patient is not acceptable. All right, and you might have a male family member or a spouse in the same vicinity that says, no, this is not okay. So if the resources allow, you can say, okay, because guys, we have to respect, just because it's not the same culture as yours, doesn't mean it's wrong. Doesn't mean it's any less important. Right? So if the resources are available, we could say, okay, let's say you're a double male truck, right? You could say, I understand. Let me call my supervisor and see if we can get a crew out here that has a female crew member, right? Guys, things kind of change a little bit if it's like a life-threatening emergency. That could be something where you have just a calm conversation to say, hey, look, I understand this is not part of your lifestyle or views or religion, but if you don't let me help, then it's possible that, they could die, they could have serious injury. If they're still refusing, then we can see if we can get a crew member of the same sex out there, okay? What about environment? What does that mean? How does that play into communicating with your patient? Okay, so neighborhood, home, where you're at.
If I'm
side of
talking,
the road in a ditch. Guys, if we're working an MVC, a motor vehicle collision or crash on the side of 75 and we still have people passing us and it's really, really loud, do we want to sit there if we can control getting the patient in the back of the truck? Do we want to sit on the side of 75 and just yell at them and hope they hear us? No. Let's get them in the back of the truck where we can kind of control the noise and the volume and we can, have a better conversation, not yelling at the patient. Also environment too, we need to take into consideration who all's around, right? Because what if this is somebody calling, they're out with their friends and whatever is going on with this patient is embarrassing to them and they don't want to talk about it openly in front of their friends, right? We could inadvertently violate HIPAA, right? If we're talking to a patient about their medical history around anyone that they don't approve to hear their responses, that's violating HIPAA. So again, if you're around, somebody that's not outside of immediate family, or even if it is like a wife or a sibling or a parent, you need to say, hey, are you okay with these people, hearing our conversation? And just clear it with the patient because they might say, yeah, it's fine, whatever, I don't care. Or you could say, if they show some hesitation, why don't me and you go sit in the back of the truck so we can have a private conversation? All right, so we got to keep HIPAA in mind and the patient's modesty and privacy in mind as well.
Instructor A,
Yes.
there's a lot of background noise on Zoom right now.
All right, does anyone, so Sydney, Jason, Keith, can y'all all mute your mics, please?
Yeah, a lot of it is coming from Sydney right now.
All right, so Sydney just muted. Keith, can you mute yours? And I think that's everyone. Oh wait, there's a second page, hold on. Diana, can you also mute your mic? Please and thank you. All right. We just talked about that. Guys, too, remember, if you're asking a patient a question, give them time to respond. Don't interrupt them. Don't cut them off. Because again, if they're giving you information that you don't really need or giving you the wrong information, cutting them off mid-sentence is disrespectful, right? It's just saying that you don't value anything that they're saying. So give them time to speak. If they're not giving you the correct information, just be like, okay, so that's great to know. That's not what I meant. What I meant to ask was, or what I need to know is, all right? The ethnocentrism and the cultural imposition, again, guys, we are here to care for patients. We are not here to preach at patients. We are not here to judge patients. So again, if you have different political, religious, lifestyle views, than your patient does, and that's going to defer how you communicate and treat your patient, you need to reconsider your career. All right, we are not judgmental. We might have two, just polar opposite views of something, but that does not change the way that you care for your patient. It does not change the way that you interact with your patient. If it does, what is that? Especially caring for your patient. Neglect. Negligence, right? So you guys really need to keep that in mind. Like I said before, just because views are different doesn't mean that somebody else's is wrong and that yours is better and that you're superior. That's not true at all. Again, we have a major melting pot in Atlanta, so you are going to come across tons of different lifestyles and views and religions and all sorts of things. So make sure that you have got just an open mind and that does not change anything about your compassion / treatment to these patients. Because not only is it a crappy way to live your life and carry out your career, but it's also illegal, right? We jump into lawsuit territory. All right. Can I get off my soapbox about that? Everybody clear? Okay. So we talked about body language. So let's talk about some body language that might, obviously, if we're construing that we don't care or we don't want to be there, that's not good to develop that rapport, right? But what if we've got a patient who is a little irritated or a little aggressive, okay? Typically, there's something that we're going to talk about in the human body chapter today. We have this reaction called fight or flight, right? Whenever we're presented with a stressful situation, typically we consider stress like a threat to us. Our brain goes into two different kind of reactions. we either get ready to like kind of fight off this threat or this stressor, or we get ready to like get the heck out of Dodge and run away. Okay. So if you are having a patient that's giving you some aggression, that is maybe, you know, cussing you out, is yelling at you, who could be possibly like threatening you or something, be aware that your body tone or your tone of voice and your body posture is definitely going to change when that comes into play. Okay. What's the very first thing we do? Always go to this first when we have an irritated patient. We want to try to do what first? De-escalate, right? If they're yelling at you, you might not even realize it because of that instinct that kicks in through your body. You might start raising your voice level at them. You might start having a different tone of voice. You might, you know, have your body posture change and it looks like you're meeting that aggression with aggression. So just make sure you take a second to try to calm yourself down. I've noticed that if you have a patient yelling at you or cussing at you, if you speak in just a calm, even, soft tone, they can't even hear you when you're talking, so they have to lower their voice if they're trying to communicate at all, right? Again, guys, don't yell back at your patient. Don't cuss back at your patient, because that's not going to solve anything. It's just going to make anything worse. Obviously, if we get to the point where our scene safety is compromised because of this aggressive patient, that changes the whole game, right? If your scene safety is compromised, that's no longer your scene. That's no longer your patient. You leave the scene if possible, and if it comes to the point from physical contact, it's no longer a patient and it's self-defense. But you have to be very careful knowing what that line is. Just because a patient is yelling at you and cussing at you doesn't mean you can haul off and hit them. All right? Your life has to be in danger. You have to be in fear for your life and your well-being before you can start going into that self-defense, like physically defending yourself mode. Because again, why are we here? To care for patients. I cannot remember if it's in this chapter, but there is a video we're going to watch where somebody does not abide by those rules. All right, guys, it's kind of sucky to say this, but as a first responder, especially in the city of Atlanta, it's part of your job to deal with the public in unsavory situations, right? It's part of your job to deal with grief, to deal with anger and hostility. That's just part of what encompasses being a healthcare provider and a first responder. So if you can't handle that, if you are just flying off the handle with these patients, then just make sure that you understand this is part of what goes into this job, being able to handle those different emotions and situations. All right, everybody good so far? Hopefully most of this is common sense. If not, I hope I'm enlightening you in how to properly talk to other human beings. So when we ask these questions, remember again, they might not have the medical information and the medical knowledge that you do. They might not know what these words mean, and make sure you're asking the most direct questions you can. Don't ask like, open-ended questions that can be responded like a novel short essay. Sometimes yes or no questions are best. Sometimes, hey, does it feel like this or does it feel like this? Giving them some options from what to choose from instead of having them have to come up with their own descriptor in their head is very, very helpful sometimes. So just make sure you're asking those direct questions so they know exactly what you're trying to ask and how their response should be. Okay. So again, keep in mind too, if they're having like trouble breathing, or if they are having something going on where they're not able to speak very well, sometimes the yes or no questions are best because they don't have to exert that energy to actually come up with words and speak. They can just give you an answer by shaking their head or nodding their head. Guys, these just go into being a good communicator. Allow them time to register what you've said and respond. Don't expect a right off the bat response because sometimes they have to think about it or sometimes come up with the words in their head. Empathy, making sure that you are letting them know you do have compassion, you do actually care, that they're having a bad day and that they're hurt or they don't feel good, right? Clarification. So if you get a response and you're like, well, did they mean that or did they mean that? don't just try to interpret that in your head. Literally ask them. So, okay, when you say that, did you mean that it feels more like this, or is it in this location? Make sure that you are 110% clear what your patient is trying to communicate to you, because if you just interpret and you interpret it wrong, then you might misdiagnose them and mistreat them, okay? So you kind of want to repeat back to your patient what they're saying. After they give you all this information, you can say, okay, so you had a heart attack 2 years ago, you take this medication, you're feeling the pain right here, it feels like this, and it's been going on for, 10 minutes. So if anything gets misinterpreted or gets lost in translation, that patient can be like, well, no, actually, my heart attack was 2 months ago, not 2 years ago. All right, so it gives them a chance to say, yes, that's correct, or no, here's what needs to be changed. All right, so going on this report, I'm not going to be able to. Yeah, absolutely.
We trust them, but we still got to verify it.
Right, I'm not discrediting anything that you're saying to me, but I want to make sure that I completely understand everything that you're trying to convey.
So it's like, John, what I hear you saying is.
Exactly. Exactly.
Correct.
Mm-hmm. Yeah. So just like, I think it was it Melody that was asking that, we want to come on scene and confirm that information that dispatch has given us. We're doing the same thing with the patient when we're talking to them to make sure everybody's on the same page.
Yeah, because there's nuances, right? I mean,
Yes.
the big thing with that dispatch is you're not boots on the ground. They want boots on the ground. So things can be lost in interpretation.
Yep. Exactly. All right, guys. So when it comes to developing this rapport with these patients, again, body language is massive. It is key. Okay. So there are some certain things that are okay to do with your patient when it comes to physical contact, and there's certain things that are not okay to do with your patient when it comes to physical contact. All right. So because of everything that's going on, I can't actually show you like I normally would in class. All right. But when you walk into a room, you need to notice the location and the position of your patient. All right. How does that factor into how we're going to approach them?
Like how you want to move them.
Okay, so maybe how we'll eventually get access to them, we'll move them to the ambulance, but that initial interaction, how does that change things?
Maybe like how threatened.
Okay, so maybe how threatened they feel?
So like on the ground, maybe like their level.
Yeah, all right, what if they're sitting on the couch? Do you want to come in and stand and tower over your patient and talk to them like this?
No, you want to get at their eye level.
Right, we want to get at the patient's level when it is appropriate. Guys, if you walk on scene and you're picking up body language from that patient, they're acting erratic, they're pacing back and forth, they've got their muscles tensed, it looks like they're being aggressive, that changes things, right? We're not going to go up to that patient and get in their personal bubble and try to make eye contact at the same level as they are, because we're concerned about our scene safety. Right? We always, if we have a patient who's acting aggressive or, kind of unpredictable, we always want to stay within swinging distance, literally. All right. So that way, if they just randomly have a violent outburst, we're not going to get, knocked out cold, and we have a chance to flee the scene. All right. But if your patient's in their living room, they're sitting on their couch, looks like they might have some difficulty breathing or whatever it is, walk up to that patient. And you can get within an arm's length of them, get on their level, right? If they're sitting down, take a knee. Don't completely sit on the ground, all right? Because sometimes that's just not good for your hygiene with some of these places we go to. But get on the same level so you can have that eye contact, so they can have more of an assurance that, you're not trying to be judgmental, that you don't have some superiority complex over them, and just make sure that you're on eye level with them, okay? Another thing that is appropriate for some nonverbal communication is what? Touch your patient. Okay, yes, smile. Don't go in with a frown with every call. But yeah, you can touch your patient, okay? So if they're sitting on the couch, you can kind of get down on one knee and you can just put a light hand on the shoulder, okay? Or you can be sneaky and put a hand on their arm, and we can start doing an assessment. Because if you walk in and you put a hand on somebody's arm, if you put it right here, you can start checking their pulse, right? They don't know that we're, like trying to already get an assessment done, but I can say, okay, is it too fast? Is it too slow? What is it telling me about their blood pressure? Maybe what does their skin feel like? Is it sweaty? Is it clammy? All right. So obviously, guys, we do keep consent in mind. Don't just run up there and bombard and get like all up in your patient's business and like, be stroking their hair and like invading their personal bubble. But a light touch on the shoulder, a light touch on the arm is okay, because what does that say? Hey, I actually care. I am invested in listening to you and talking to you and fixing your problem. All right. So just remember that personal space. Again, don't get way too up close and personal. Don't have too much inappropriate body contact, but that light hand on the shoulder or on the arm is totally, totally appropriate. Okay. Everybody okay with that? We talked about don't interrupt them. Don't speak in that superiority, context of you're using all of the medical verbiage and terminology, and you're so stupid if you don't know what I'm talking about. That doesn't go over well. So again, guys, who are we going to approach first to get this information? The patient. Guys, I can't stress that enough. You will be surprised. So many EMTs and so many paramedics, they walk on scene, and if there's like a family member or a bystander, they just leave the patient in the dust and they go directly to that family member. Hello, I'm over here. I'm the one that's having a problem, right? So again, like I said before, we're going to have that same initial approach to every single patient. Okay, we're going to walk in the room. We're going to make that eye contact. We're going to try to get on their level if it's safe and appropriate. And we're going to talk to the patient first. Guys, introduce yourself. Like, hey, I'm Kayla with Grady. What's going on today? How can I help you? All right. Based on that patient's response, whether or not they are altered, if they're confused, if they're, unresponsive, if they're just acting erratic, then I'll remove myself and say, okay, I'm not going to be able to effectively communicate with this patient. And then I'll say, okay, is there a family member? Is there a caregiver? Is there a bystander around that can tell me what's going on? Guys, don't bypass your patient. That's going to be the first person you go to, the first source you go to for this information and that communication. Now, if we've got someone just like laid out on the sidewalk and it's very clear and obvious that they're unconscious, unresponsive, we're probably, might not go up and be like, hey, sir, how you doing? My name's Kayla. We do want to check their level of responsiveness, because sometimes their eyes can be closed, but if we talk to them, they might be like, oh, hey, you're here. Or if you give like a painful stimulus, that can wake them up too. But again, guys, use your just common sense and your discretion, but always, always, always approach that patient first before you bypass them to talk to somebody else. Because if you call 911, right, and you have a problem or you're hurt and the EMTs walk right past you and go to your roommate or something like that, and like knowing that you're the patient, how does that make you feel? Yeah, hey, I'm here, take me seriously, like show that you care. Okay. Family members and bystanders can be super helpful, or they can be super harmful. Okay. Because you might get on scene with family members or bystanders or just people who don't know this patient, who are just like, they saw what happens, and you're trying to talk to the patient, but they're trying to get the answers. All right. So if I'm trying to talk to you as a patient, and let's say, you're a bystander and I'm trying to talk to you, and you're like, oh yeah. So I'm asking you what happened. Before you can get 2 cents in, it's like, oh, I saw what happened. She did this and then this happened. Okay, that's great. Thank you for wanting to help, but I need to talk to the patient first. I need to hear her responses, and then, I'll ask you any other questions. All right, guys, if they just can't take a hint, then it is totally appropriate to say, hey, I need to have some privacy with the patient. You can throw HIPAA in there. Be like, I cannot violate HIPAA. There's legality here. I need you to step away, or I'm removing the patient, and we're going to have a private conversation. That's totally fine, but just be mindful of your tone of voice, of the words you use, of your body language. Okay. Because if you come across to that bystander or that witness or that family member as, dude, get the F out of my way, you're going to get what you give, and we might start having a hostile situation. So just say, hey, I really appreciate you trying to help. I need to talk to the patient. I need to hear it in her own words. or, actually, I'm legally bound to keep this conversation private. We're going to go to the ambulance, or I need you to step out. Or you can do what? You can kind of trick them a little bit. Give them something to do, right? Even if it's something that we know is not relevant. Hey, when she goes to the hospital, she is going to need her phone charger and her insurance card and all of this. Can you go get that? We need to take that to the hospital with us. Because most of the time, these family members, these bystanders, they want to help. They want to be involved. They want to feel important or relevant to what's going on. So if you give them a task, hey, can you go get her favorite fluffy pillow or her blanket, like whatever it is, you can remove them from the situation long enough to talk to your patient or to kind of get things kind of under control. So you can give them, like, sometimes it is meaningful. Hey, she is going to need her ID, this, that, or you can just give them something to do to make them feel like they're helping, but you're really just getting rid of them for a little bit.
Is that be appropriate with parents and minors?
Yes, that is a beautiful way, and we'll talk about that in a minute, to get candid responses from minors if the parent's a helicopter parent. So we'll talk about that in a little bit. Talked about that. All right, guys, so ultimately everybody's aware of what the golden rule is, right? You need to be treating these patients like you would want somebody to treat your loved one or yourself, right? Whoever you hold most near and dear in this world, if somebody showed up, a crew showed up, you need to treat your patients the same way you expect that crew to treat that family member, okay? That should just be common sense. It should just be normal human compassion, but some people need to be reminded of that. So just make sure that you're conveying yourself in a manner that you would be okay carried out on your loved one. All right, we'll jump into that. All right, questions, comments, concerns so far? Everybody good? All right, so some things to consider with some elder patients. Now, guys, notice I said consider, not assume. Just because a patient is geriatric, which we consider the age 65 and older, geriatric, does not mean that they can't hear. Doesn't mean that they, are a senile little grandma, all right? So make sure that's another thing we don't do, especially when it comes to contacting with the patient first. If there's a caregiver on scene, don't bypass that elderly patient because you're just like, oh, they're old, they've got dementia, they don't know what they're talking about. That's very offensive if it's not true, okay? So some things to consider, that you might have a baseline altered mental status. What does that mean, baseline?
They're already altered.
Their normal presence, right? So why might we have a baseline altered mental status? Okay, so if we do have some dementia or if we do have some Alzheimer's, right? They might every single day be A&O times 3, and that's normal for them. We need to try to establish that when we're talking to the patient, because if they're always every day A&O times 3, and I'm assessing that they're A&O times 3, then am I really concerned with that? No, that's normal for them. But if I can establish that they are normally A&O times 4, smart, or sharp as a tack, and I come on scene and they're now A&O times 3, now am I concerned? Yes, that's different from their normal. All right. So we need to establish that baseline, because there have been not several, but more than ideal occasions where crews will bring in patients from, say, a nursing home or something like that to the emergency room and call a stroke alert. They'll call in and say, hey, this patient's having a stroke. We've got altered mental status. You need to get the CT scanner ready. You need to get the neuro team down there. We're doing the whole 9 yards. They don't bother to gather their baseline mental status. They are altered. They're A&O times 3, but guess what? They're always A&O times 3. All right. That is not a pleasant conversation to have with the stroke team when you're like, she's always like this. Why are you calling a stroke alert? So establish your normal baseline mental status for these elderly patients, okay? Because guys, if they have Alzheimer's or dementia, they might not be aware of any of their history. They might have a confused perspective as to where they are, what's going on, why you called 911 was called, type thing, okay? So if possible, if they're at like a nursing home, talk to the staff if they have any kind of family member around them. Again, we'll approach the patient first and then adjust our interaction appropriately depending on that patient's response. So hostility and irritability. Guys, has anybody ever seen anyone go through dementia or Alzheimer's? It sucks. It's really, really shitty. Excuse my language. But it can actually alter the patient's personality, right? So my peepaw, he was the nicest. I mean, like, blushed at curse words, wouldn't hurt a fly. But when he started going through and really got progressively into Alzheimer's, he would have violent outbursts with the people at the memory care center. He would say every name in the book. So again, we need to understand there's different reasons that patients are acting like this. All right, are you going to take offense to an 87-year-old grandpa who is cussing you out? No.
No.
Right, guys, that's part of that horrible disease that is Alzheimer's. We can't have these violent outbursts. We can't have these, just random like cussing you out and saying offensive things just because their brain is not working correctly. All right. So again, don't take offense to that. Don't threaten. I'm going to tie you down, old man, if you don't shut your mouth. No, that's not okay. Take a step back and understand that this could be normal for them and it's nothing personal towards you. All right. All right. A big thing to understand with elderly patients, guys, globally, what starts to happen to our bodies the older we get? Everything starts to kind of not work as well, right? All of our organs, all of our systems, everything just slowly starts to get chipped away at and starts to just kind of shut down and not work as efficiently. That includes your nervous system, all right? Elderly patients a lot of times don't perceive pain like everybody else does. Like they physically can't feel pain as much. They have an extremely high pain tolerance. So again, when we jump in a patient assessment, we'll talk about that more, but make sure you're doing a thorough assessment on every single patient, okay? I have had a patient like this. We got a call for a ground level fall, which means that they fell at the height of their body. They didn't fall like from anything. And we get to the house. I think it was the patient's nephew that was there taking care of her. She was in the back room. She was cuddled up in her bed and she was talking to me. She goes, "No, sweetie, I fell and I was trying to go to the bathroom and I fell down and I got back up. I'm fine. I don't need you to take me to the hospital. I'm fine. I didn't hit my head or anything. I'm okay." I'm like, "Okay, well, let me get some vital signs. Let me just give you a good once over just to make sure, I don't find anything that I'm worried about." She's like, "Okay." Pull the covers back and I say, "Ma'am, I really, really think that we need to be going to Grady today." "Oh, I'm fine. What's wrong?" I said, "Looks like you've got a broken ankle." And she goes, No, what are you talking about?" Guys, her ankle was like totally 90 degrees deformed. And I said, can you sit up? I need you to look at this so you can see what I'm seeing. She goes, "Oh my, okay, let's go to Grady." Guys, she didn't feel it, right? Different medical conditions can cause you to lose sensation in your extremities as well. But the older we get, we lose that pain sensation. So make sure you're not missing anything. Because had I just been like, "Okay, yeah, you're fine. You don't need to go to the hospital," and not notice that could have been some really big complications. Okay. So just make sure you're aware that they might not be perceiving pain normally like other people do. All right. Make sure if they have any other type of deficits like visual or hearing, make sure that we're taking their glasses, their hearing aids, maybe a cane they might need to use to be mobile. We'll get to that a little bit further in this chapter, but just make sure we're taking all of these things that they will need to, function like they normally do at home. Guys, offer to the elderly are very hesitant to leave their homes because, especially if nobody else lives there, if they're home alone, they don't like to leave their belongings behind. All right. This stems from some of the elderly generation that maybe went through or experienced something from like the Great Depression, where their belongings are very important to them because at one point they didn't have anything. So just offer, hey, we can bring your purse. We'll make sure we get that. I will go get all of your stuff, and I will make sure I lock the door behind us. Okay, guys, you can do that. That's totally appropriate. Just assure them that you're going to do everything possible, because they might really need to go to the hospital, but they're like, no, I can't leave here. I don't want to, leave my house unattended. Just do everything that you can to assure them that that shouldn't be the reason that they don't go get that medical help. Kiddos. All right, communicating with kids. Has anyone in here never interacted or been around younger children? No? Okay. There's always usually one in every class. Guys, kids are a whole nother ball game. Why? How are we going to have to change the way we communicate with them?
It has to be simplified.
Okay, it has to be simplified. I can't use any medical terminology whatsoever with kids. I guess we're talking up to probably like middle school age, because at that point they start developing some maturity. They're able to carry on conversations a lot better. But yeah, I'm going to have to use like very simplistic terms. It's not going to be abdominal pain. It's going to be, does your belly hurt? Does your tummy hurt? Right? What else?
They may be afraid. You have to help them calm down.
Guys, because I will tell you right now, if we're being called to a kid, sometimes it's something that doesn't require 911 in an emergency room, but if they're really sick or if they're hurt, who do they want?
Their parents.
The mom.
They want caregiver. It might not be mama, it might be daddy, it might be grandma, it might be auntie, it might be whoever is a sense of comfort for that patient, for that little kid. They want mama, right? So probably most likely, where are we going to find them? With that caregiver, usually in their arms. So they don't feel good, right? They want mama. And if we roll up in this big, loud, shiny, lights flashing truck, and we get out of the truck, guys, the uniforms, we do look like police officers sometimes. A lot of people misconstrue us for police. That's scary to them, because what are they thinking if we're walking up with these big jump bags and we've got the lights going on the truck and they don't know who we are and we got these big clunky boots and we're approaching them?
They're going to be taken away.
Either they're scared that they're in trouble, or we're going to take them away from mama. That's not good, right? They're going to go into freak out mode. So just make sure that you understand that we can come across as scary to them, especially if they're in the whole stranger danger phase. So when we approach them, we want to be very, calm and kind of playful with the kid, right? Guys, this is if the kid is stable, right? If the kid is like unconscious, none of this is applicable, right? We're going to take that kid. We're going to do everything that we need to. But if kid is aware that we're here and they're ANO times 4, whatever it is, then these are things we need to keep in mind. How might we ease that interaction with this pediatric patient?
Like use a mom voice.
Okay, so maybe use a mom voice if you know what that is. Yeah. So just like, hey, bud, what's going on? Right? To let them know that we're just not like mean people. What were you saying?
No, I'm saying get down on their level.
Yeah, make sure you get down on their level. Okay, so kind of crouch to where you can see them.
Like tell them how tough they're doing or how like.
Yeah, right? Play it up. Be like, oh man, you're so brave. You're so tough. You're so strong.
Be aware of like where they're at in their like operational stages, because you don't want to like offend the kid too.
Okay, so yeah, we don't want to go up to like a middle schooler or a high school and be like, hey buddy, what's going on? Do you have a bellyache? Can you, do you need some medicine? Like, just be aware of that. And we'll talk about that in the lifespan development chapter, but yeah.
Maybe they have a comfort toy that they.
Yeah, guys, if they've got like a blankie they're holding on to or a stuffed animal, let them keep it. If it's not hindering your assessment or your patient care, bring it on. All right. So we're going to try to do as much of an assessment on these pediatric kids before we even touch them. Like when we're walking up to them, we're looking at different things. We'll talk about that later. But who can we involve? Mom, right? If we are understanding there's no way we're going to be taking this kid out of mom's arms and they're not unstable and they don't need immediate care, let mom hold them. Let mom be involved. If they need any type of like oxygen or any type of medication, Let mom help try to deliver that medication. Let mom, kind of talk them into letting us do what we need to do. All right. So we can tell mom, hey, guys, does anybody here have kids? Okay. So if you are around little kids, like my 3-year-old and my 10-month-old, if they fall down or if they do something that like initially scares them, the first thing they do, like let's say my 3-year-old, he's running. Sometimes he doesn't see walls. He just runs right into corners. And so he'll fall down. And the first thing that he does is what? Look at me. They're going to see how he's going to see how I'm going to react. Most of the time I start laughing. But if he looks at me and I have a, oh my God, you're going to die face, then he's like, oh my God, mom's freaking out. I'm freaking out. It's the end of the world and he's going to lose it. Right. But if he looks at me and I just start laughing, he's just like, oh, mom's cool. It's fine. It's no big deal. And he'll laugh it off. So try to get mom's emotions or caregiver's emotions on the same level. If you can convince that kid, let mom convince, hey, it's okay. They're not going to hurt you. Like, it's a cool truck. Let's go back here. Everything's fine. Then they're going to be a lot more willing to cooperate, let you get a blood pressure, let you do whatever. Okay. So a couple things to keep in mind. If they are like school age and they can like understand things, you need to be honest. If you need to check a blood sugar, it doesn't really hurt, but it doesn't really feel good. Right? Has anybody ever seen Elf, the movie Elf, when he goes to the doctor's office and he like sticks his finger real quick and like he freaks out? Yeah. So let them know if you need to do that, be like, it's going to be really, really quick, like just a really quick little stick, and you're so brave and you're so tough and you can do it, and then it'll be over. It won't hurt anymore. Because if you are trying to do something that is going to be painful and you tell the kid, oh no, it's not going to hurt, it's fine. The second that you prick that finger and they realize you lied to them, oh, it's over. You are not going to be able to do anything else with that kid. You lied to me, you're mean, you're scary, and I don't like you. Right? They're not going to cooperate with you anymore. So be honest, try to downplay it. Like with the finger stick, it's just going to hurt for just a second, which it really does. But just make sure you're being honest with them. Guys, it's fun with kids. If they're not sick or they're not injured, you get to be a little bit of a kid yourself, right? You can talk to them about like, who's your favorite cartoon character? What's your favorite movie? Or if they have like a dinosaur on their t-shirt, like, oh man, that's such a cool dinosaur. If you're okay with it, I several times, I'll pull Netflix up on my phone and let them watch cartoons on my phone. So they're distracted and I can do what I need to do. All right, if they see me as a friend, they're going to be a lot more cooperative with me, and I'm not going to have to, fight the kid, not like fight the kid. But, the situation is going to go a lot more smoothly. Get the balloon, blow the balloon up, or I'm sorry, the glove, right? Tie it off, make a little smiley face on it. Like, do whatever you need to do. Get the kids incorporated in their own care, right? They don't know what a stethoscope is if they're young. They don't know what a cardiac monitor is. They don't know what a blood pressure cuff is. All right, so if you need to listen to lung sounds or you need to take a blood pressure or something, like, oh, look, this is super cool. Do you want to hear your heartbeat? Or do you want to see your heartbeat? Like if you put them on the monitor, let them play with it first. And be like, that's really cool, isn't it? Now can I do it? So A, they know it's not going to hurt. And B, it's like you're involving them. It's kind of like a game to them, okay? Hearing impaired patients, guys, just remember if they have like a hearing aid device, unless you are well versed in like the manufacturer or the make and the model of that, don't really try to play with that as much because they're expensive. We don't want to break them if they're not working. There are some things that we need to keep in mind when it comes to patients who have some hearing deficits. What are some things we can do if their hearing aid's not working or they don't have one to better communicate with these patients? Write stuff down, right? If you keep a notepad with you, just, hey, write a question, give it to them, give them the pen, let them respond. Or you can print out, you'll all have a cardiac monitor on the truck. You can print out the paper that those 12-lead EKGs come on. You can like just print it out blank, use that to write on, okay? What else do we need to keep in mind?
Just because they can't hear, they're not capable of answering the questions.
And just because they can't hear, if they can't see, doesn't mean that they're dumb, right? Don't get that mentality. What else? A lot of people who were maybe born with hearing deficits or have had it for a very long time learn how to do what? Read
And
lips.
read lips.
Okay. So if it comes to that, you might think you're doing them a solid by talking really, really slow and really enunciating every word. But that's a hindrance. If you talk elongated like that, it changes the way your mouth moves when you speak. So don't be like Speedy Gonzalez and talk super, super fast, but just talk in a nice, slow, normal tone and normal pace. And they should be able to read your lips better than if you tried to extend it out. You can try to maybe raise your voice a little bit if they are hard of hearing and not have total hearing loss. But again, guys, don't come on scene if it's an elderly patient. Be like, hey, sir, how you doing today? And they'd be like, dude, I can hear you. Don't just assume that we have these deficits if they're elderly. There are some simple, if you guys are familiar with ASL, the American Sign Language, there are some simple medical terms that you can learn. So this means hurt. So you can be like, where does it hurt? This means help. So it should be like, I'm here to help. And then sick. So just some simple things. Guys, you don't have to be fluent in sign language. You can just use body language. You can use charades to try to better communicate with these patients. Questions, comments, concerns? Everybody good? All right, so visually impaired patients, guys, again, there's a spectrum. You can be totally deaf, you can be totally blind, or you can have just some subtle on that scale hearing or visual loss. What if you have a patient who is totally blind? What do you need to be aware of?
How you come across somebody because they can't see, so you just go and touch them.
Right.
You're gonna freeze them out.
Guys, I cannot imagine how vulnerable and how scary it would be to not have one of your senses, right? With hearing and especially with seeing. You don't feel good, you're hurt, and you can't see anything that's going on around you. That's extremely scary. That's extremely intimidating. So once we gather that they have, a total visual impairment, make sure you are letting them know everything you're doing before you do it. Because if you can't see anything and you're in pain and somebody just comes in and all you hear is noise and people talking to you, and then you hear feel like a hand on your shoulder, or somebody grabs at your arm to get a blood pressure, or when you move into A, if you try to go start an IV without telling these people what you're doing, that's not okay. That's very scary. So just be like, once we establish it, hey, you're gonna feel me touching your left arm, I'm gonna get a blood pressure, it's gonna squeeze your arm, and then it's gonna let go, or hey, I need to, access whatever part of your body to do an assessment, you're gonna feel me over here. Make sure you're talking step by step. We should probably do that with every patient, right? Be like, hey, do you mind if I get a pressure, instead of just grabbing an arm, or just letting them know, hey, I'm doing this, or I'm gonna do this if it's okay. But just make sure you're letting them know what's happening before you actually do it, so they're not caught off guard and it doesn't make the whole situation even scarier. Again, try to, if you can, help them walk to the stretcher. If they need a cane or anything to bring with them, make sure we bring that with us. Animals, true or false? We can transport service animals.
True.
Who says true?
I do.
Then it's false. It's true. All right. So yeah, we can transport service animals. There are a couple things you guys need to know about this that can make it a little bit of a sticky situation. Okay. Typically, what do we see service dogs or therapy animals for? So typically we see them, they have some type of identification, like a vest. Usually we see the vest, like that. What do we typically see them for? What kinds of patients have them?
Those who deal
Okay,
with
so
anxiety.
blinds, like a guidance dog.
It's a therapy dog.
Okay, so a therapy dog, maybe they have some really bad PTSD or anxiety or something. But yeah, a lot of medical conditions, right? If you have a seizure condition, or if you are a really bad diabetic, guys, it's mind-blowing. We don't deserve dogs in this world. It's crazy because these dogs are trained. There are certain hormones that are released and chemicals that are released before you have a seizure or as your blood sugar starts to drop. They are trained to pick up on that and sense it and smell it and understand that that's bad, and then go alert their owner, hey, dude, you're about to have a seizure. Because if you have a seizure disorder, what if you're cooking it with a, you know, a hot pan in the kitchen and you have a seizure? Or what if you're holding a baby and you have a seizure? Like, they let these people know so they can kind of like drop what they're doing and like sit down so they don't get hurt. They can check their sugar. It's crazy, crazy cool, right? Now, in accordance with the ADA, the American with Disabilities Act, if we come on scene and we have a patient who has an iguana on their shoulder and they say, this is my service iguana, it's my therapy iguana, and it has to go with me. How do we handle that situation? Do you typically see an iguana as a service animal? No, not
No.
really. But with ADA rules, we cannot do what?
We can't deny them the transport of that animal.
So we can't deny them if they truly are a service animal. But also, we can't ask them to prove if it's a service animal or a therapy dog. Typically, guys, if it truly is, they will have like, you know, an identification marker, a vest, either papers, something that says that this animal has been certified. All right. If the iguana is wearing a tiny vest, then yeah, I'll go for it. But if the iguana is just sitting on their shoulder, I can't say, well, you know, if you say that's your therapy iguana, I'm going to need to see documentation that it actually is a therapy iguana. I'm violating ADA if I'm asking them to prove. That is a lawsuit. I can't even ask them, well, why do you have a service iguana? I can't ask them why they have it in discrimination to not wanting to transport. I can ask why you have it to get like some medical history, like do you have seizures, do you have this, do you have that? But if I'm questioning whether or not that's going to be a credible service iguana, I can't even ask what their medical condition is. So guys, use your discretion. Typically we see dogs. Sometimes you see cats, but it's usually dogs. If you come on scene and they're like, yeah, that's my therapy alpaca, you got to handle it carefully. Okay, because can we fit an alpaca in the back of our truck? No, right? But you might want to contact supervision and be like, hey, this is what's going on, guys, even with an iguana or like a snake or something, like something that you don't typically see transporting with patients. Just be like, just making you aware, you might want to talk to Grady and let them know that a snake's going to be coming in with this patient, because I can't rule out that it is or is not a service snake. Okay. I have had a guinea pig one time. That was very questionable, but we transported it.
So did you bring like a cage with it or something like that?
Oh no, like they had it like in a purse.
Instructor A.
I did not find out. I just let Grady deal with it when we got to the hospital. Yeah. So guys, if it's feasible, if it's not going to be a danger to you, like if it's a scene safety issue, like you know, the guinea pigs like trying to bite you, or like the snakes, like, you know, whatever, that's different. But if it's feasible to transport, go ahead and transport. I would have a step aside from the patient, call supervision on the phone, because everything we say over the radio is recorded. Just say, hey, just let you know this is what's going on. We went ahead and transported, but we need to get some communication going on with Grady before they deny, you know, taking this patient or the guinea pig or whatever it is.
I was gonna say, one thing I didn't see in there for visually impaired is place movements. So my mom's lost her eyesight over the last 20 years. And when it started, I mean, not a big deal, but when she lost her peripheral vision, she functions because she has stuff in specific places. And so
Yeah.
if you move that stuff,
Mm-hmm.
that could be incredibly dangerous. And
True.
I didn't get that when I was, you know, about 10 years ago.
Yeah.
I tripped over something and visited.
Yeah, so
You
try to
gotta be
keep
aware of that kind of
everything
stuff, too.
intact.
Right.
Obviously, if it's like a life-threatening emergency, it's a little different if we do have to displace and stuff. But yeah, try to keep everything in
Well, I'm
its
thinking
place.
like your bags and when you move and stuff, you gotta be careful when you
Yeah.
pick that up, because, I mean, that's, you're gonna take a trip on that.
Mhm.
and you know the problem.
Absolutely.
What happens when a service animal gets in the way of care? Like, I know dogs can sometimes like want to lay on their owners for like anxiety and stuff.
Right. I haven't personally come in contact with that, but I would just imagine, you know, if you can tell the owner to give them some kind of command, because guys, you can tell if it's a service animal. They are meticulously trained. They have a very calm demeanor. They obey commands extremely well. If you've got just like a little Pomeranian just like running around and just like yapping the whole time and not really like listening or doing anything like that, then we're probably gonna in the back of our mind say, oh, it's probably not legit. But yeah, just ask maybe if we can get the owner to physically remove it, or if not, then we can just physically remove the animal. Be aware there are therapy dogs. Okay, my mother-in-law, she breeds and shows dogs. One of them's actually like legit a movie star. It's been in several Hollywood movies. It's freaking crazy. Has her own Instagram page and everything. But she has gotten her dogs certified as therapy dogs or like anxiety dogs. So when she travels, having that companion with her eases her anxiety, and you can legit get that certified as well. So it's not just service dogs, you can have therapy animals as well. So keep that in mind. We talked about the language line. Guys, you can use like Google Translate or any app on your phone, but try to utilize the Grady language line because it's an official resource, right? If you call Grady language line, it's recorded. If there is any misinterpretation that leads to a misdiagnosis or mistreatment and any harm towards that patient, you can go back and say, no. I talked to Bob on Grady language line, and he confirmed that they were not allergic to aspirin. So he said they weren't allergic to aspirin, so I gave him aspirin. All right, so it's something official that you're going to document, right? You're going to say, talk to Bob on language line. Bob was the interpreter. So that way, if something happens, it sounds bad because you're trying to have all these people to throw under the bus if something goes wrong with your patient, but it's something that you can actually track and prove that you utilize this official translating service versus like Google Translate, because that's not like endorsed by Grady, if that makes sense.
So like if a family member or a friend or something is translating, not the patient or like Grady, then what can you do if they
Be careful with that as well. You can use family members, you can use like friends or whatever, anybody on scene, or you shouldn't ever have a problem getting the language line on the phone. But if you do, just notate in your documentation that, so-and-so provided translation. Get a name, get a relationship to the patient. But again, if there's anything lost in translation, you're not going to have an official resource to kind of go and blame, if you will. It's a bad term, but. All right, so other healthcare professionals, again, guys, we kind of talked about this yesterday. Make sure you have a good relationship with these doctors and these nurses and these medics in the hospitals, because we don't want to piss the doctor off. And then when we bring a patient in, they totally discredit that report, that information you're relaying to that patient because they just don't like you, right? Very important to give a thorough report, include all of the information, all the drugs, interventions that you've given, any allergies, anything that's really relevant to what's going on with this patient. We'll go over what that is in patient assessment. But just make sure you've got a good relationship, because your patient is going to be the one that suffers if you're butting heads with these people at the hospital as well. So giving a report, all right? So this is really important. You need to understand what is included in a report, because we don't want to leave anything important out, right? There are two different kinds of reports that you're going to be given. There's going to be a radio report, which is given over the radio, and that's going to be given before you get to the hospital, right? City of Atlanta has radio systems where we can get in touch with the hospitals over our radio. We go to a different channel, but we can call and report to the emergency room. There's a paramedic or a nurse that sits by that radio and takes all of these reports coming in before you get there. Why do you think that's important? So the hospital can be ready. Ready with what? Right. So with whatever resources the patient needs, right? If you're bringing a patient who is a really, really bad, sick, critical trauma patient, all right, where do we need to bring them first off? A trauma facility, right? But we want to go ahead and activate a trauma alert with these hospitals. I'm going to get Grady on the radio and be like, hey, Grady, I'm coming to you with, blah, blah, blah. This is going to be a trauma alert activation. So they know, okay, this dude is bad off. They're going to immediately get on the phone with all of the trauma team in the trauma bay, make sure there's a room open, make sure everybody that needs to be down there, maybe respiratory therapy, pharmacy, get that x-ray machine, that mobile x-ray machine ready to go. So there's not any delay in care when the patient gets to the hospital. Everything is there waiting on the patient.
Do you give them a video?
No.
You just say,
Correct.
they're on the-
Yeah, guys, we don't give anything that can violate HIPAA over the radio. Okay. Maybe some of that changes in the verbal report that we give when we get to the hospital. But when you're given a radio report, we want to know the meat and potatoes of what's going on with your patient. All right. We're going to start out with age, sex, and complaint. So age, sex, complaint. It's going to be the first thing we lead off with. Okay. Then we are going to give just a very brief, hey, what are my vital signs? Because that's going to tell the hospital how stable or how critical they are. What have I done for my patient? Have you given any drugs? Have you given them oxygen? Are you breathing for them? Maybe how they responded to those interventions. And then how far away you are. And guys, throw in there after that age, sex, and complaint if you're activating anything, like a trauma alert or a stroke alert or what we call a STEMI. That means that somebody's having a heart attack. Or a sepsis alert. That's a pretty new thing that hospitals are doing now.
What was the one after how they responded to the intervention?
How far away you are, what your ETA is, your estimated time of arrival. Guys, when you call a radio report, it should be no longer than 30 seconds. Okay. So especially at Grady is so busy, guys, but all different services from the entire Southeast bring different patients into Grady. Okay. So we don't call a radio report if it's something that's very minor. If it's that stubbed pinky toe on the coffee table. If it's abdominal pain that we suspect is just straight up abdominal pain and nothing else. We don't really call those in over the radio because those wavelengths can get tied up. And if somebody's bringing a trauma alert, a STEMI, a stroke, a burn patient, they might not be able to get through because I'm talking about pinky toe pain. Okay, so only those significant critical patients that you're activating an alert for will call over the radio for Grady. Other hospitals, you can call in the smaller stuff. But they want to know about the big things that they're going to need additional resources for. All right, so, we're going to start out the report. We're going to raise whatever hospital we're trying to get in touch with. Grady ECC, this is Grady truck 123. We're going to let them respond, right? I want to know they're listening to me. You'll hear somebody else on the radio, this is Grady ECC, unit 123, go ahead. They'll give you permission to say, hey, I'm listening. I can write down everything you say. Go ahead and give me a report. All right. So for example, I'm bringing you guys a 35-year-old male, chief complaint, GSW, which means gunshot wound, activating a trauma alert. All right. If it's an injury, give a little bit of detail about the injury. We've got 3 puncture wounds to the abdomen. All right. Maybe 1 to the left upper quadrant. We've got maybe a right pneumothorax, blah, blah, blah. His pressure is, 70 palp. Heart rate's 124. We've got bilateral 18 gauge IV started. We've got some fluid resuscitations on board. We're currently bagging them with an OPA in place. And we'll see you in 5. Okay. That's going to be like a 15-second report, guys. If you just go on and on and on over the radio, they quit listening after about 5-10 seconds to see if it's like legit or not. All right. So a lot of times we'll throw in a GCS. I'll talk about that in a little bit. But just the meat and potatoes for your radio report. Okay. The verbal report, once you get to the hospital, you can throw in more information. It can take longer. You can throw in maybe, this is Mr. Jones. Mr. Jones having abdominal pain and, throw in a lot more information. It's not as important that we get everything in a very timely fashion with these verbal reports. But guys, just make sure you don't leave anything out, right? Especially like allergies or any medications you've already given, because why might that be bad?
They don't want to have a reaction if they have to give something.
If they don't know that patient's allergic to a medicine and they give it to them, that's not good for the patient. Or if I've already given this patient medication and I've reached the max dose of that medication, they can overdose the patient because I didn't tell them that I gave them anything, right? So make sure you're including every important aspect of that information and that treatment in your report so the patient doesn't have a negative outcome. All right, so PCR, patient care report, that's going to be your documentation, your written chart on your patient interaction, okay? Again, guys, this is a legal document. So you also heard too on that video yesterday that paramedic or that EMT said, yeah, I knew this was going to be a case that probably went to court. So I asked my supervisor to take me out of service so I could chart everything correctly, like while it was fresh on my mind. I highly suggest you do that, right? The cases that the calls that I've ran that I'm like, yeah, this is going to go somewhere. I call supervision. I say, hey, I just ran a child abuse case. Can you take me out of service for 30 minutes so I can make sure I get this chart done correctly? All right, guys, make sure what is included in your chart. Everything, right? From start to finish. How did you find your patient? What did you notice on scene? How did your patient respond to you? What are the words your patient used? What did you do for patient care? How did you get them to the ambulance? How did they respond to those interventions? What were their vital signs? All right. Who did you give report to when you got to the hospital? That's important, right? If you give a verbal report to, Nurse Sarah, include that. Make sure you get that signature and say patient care transferred to RN Sarah Jones. That's important. All right. What else? Yes.
Is this something you both people think? Like both people do PCRs?
So how it works, guys, if you are what we call teching the call, that means you're in the back of the truck while somebody else is driving to the hospital. That is going to be the person that writes up the entire chart. Now, let's say your paramedic is in the back, they're teching that call. They're going to write that chart. But on scene, if you got a blood pressure or if you gave the patient oxygen, the paramedic is going to include your actions and your treatment in their chart. But you don't have to write one. You're going to be included in that paramedic's chart because you provided patient care, but it's only going to be one chart for every patient.
So how do you know if you should take yourself out the game for a few minutes? Do you just use your own judgment, or like?
If it's any type of maybe a domestic dispute, any type of abuse or neglect, or maybe it's a crime scene, anything like that, there's probably a 90% chance that it could go to court. Make sure you might not need extra time. You might be able to chart like maybe on the way to the hospital or at the post or at a post or whatever. But just make sure you'll know, like a run-of-the-mill abdominal pain is not going to be as important as a shooting, right? Because that's going to be pursued no matter how you look at it. So anything that's criminally involved, make sure you guys are charting.
If there's multiple crews like on the scene, then who does the chart?
Whoever the patient ends up in the back of their ambulance. Whoever rides in with them. All right. What else? What else is included in your chart? What kind of information? Non-biased. Objective. All right. Objective. Sorry?
Just facts.
Yeah. Objective is factual information that you can measure. Okay. Subjective is going to be any kind of opinion or interpretation of stuff. We don't want anything like that in our chart. Okay. Let's see. All right, we'll get to that in a second. We'll harp on that. Guys, there are still out there in the world written paper charts. We do still keep paper charts in the back of the truck at Grady just in case like the internet goes down or our technology goes down. Those are, again, straightforward. They're self-explanatory. They have check boxes. They have things that you circle. It's kind of like a fill in the blank. They have a part where you can write out like your narrative, but it's just done by pencil or pen versus typing it on a computer. Okay. Most everyone has gone into the the E-chart. This is an example of the ESO. That's the software we use here at Grady. A lot of this stuff is drop-down boxes, right? You'll notice that, you know, you can say that click here, the patient improved. Click here if you called medical control to get any orders. You type in the physician name here. You're typing in the vital signs. You're typing in the time that you did these vital signs. So a lot of it is kind of fill in the blank. You will always, always, always have a free type space narrative for your report. Okay, what needs to be included in the narrative? Pretty much everything. Tell me a story. Tell me what happened from start to finish with the patient interaction. All right, and more importantly, this is where you justify your actions, right? This is where, based on your set of protocols, you tell me why you did something outside of those protocols, or maybe why you withheld something that you're supposed to do according to those protocols. All right, so let's say my chest pain protocol. It says that I need to get a 12 lead on that patient. I need to put the stickers on their chest and look at their heart. I need to give them 324 milligrams of aspirin. I can give up to 1.2 milligrams of nitro, and I'm going to give them oxygen as needed. All right, there's 2 alternative medications I can give if that chest pain's not relieved with that dose of nitroglycerin. All right, so if I'm charting the chief complaint that I use a protocol chest pain for this patient, and I only gave them 1 nitro pill, how many am I supposed to give per protocol? Oh, wait, sorry, you guys don't know that. All right, so I only gave them 1 pill of nitro when they're supposed to get 3. Okay, QA is going to open up that chart and be like, well, hold on. Why didn't you give the 3 doses of nitro? You only gave 1, you're supposed to give 3. If I don't have anything written in my narrative why I only gave 1, that's a problem. They're going to contact me and be like, hey, why didn't you follow protocol? You only gave 1 pill, you're supposed to give 3. All right, so, but I'm going to correctly and thoroughly chart and document that call, and I'm going to say, patient administered 1 pill of nitroglycerin, all right, and then after 5 minutes, the patient's blood pressure dropped too low, and I couldn't give them the additional 2 doses of nitro. If I'm justifying why I didn't do something, QA, they'll read that in my narrative and be like, oh, okay, no problem. It's clear, black and white, why she withheld that extra dose. Okay, what about like maybe restraining a patient? What do I want to have in my narrative for that?
Why they were restrained?
Why I got to the point of physically restraining them, right? This is where it gets a little fun. All right, because I need to, in my narrative, I need to justify why I physically held this patient down and tied them to a stretcher, right? I can't just put that I did that and have no reasoning in my narrative. So we can use quotes, direct quotes from patients and bystanders and family members in our narrative. Now guys, be careful with this because it needs to be an exact quote, because if you're typing in like some extra stuff that the patient didn't directly say, then they can go back and be like, oh, no, that's liable defamation. I didn't say that. All right, so make sure it's an exact quote, but you can use exact patient quotes to justify why you physically restrained your patient or chemically restrained your patient. All right, patient was not responding to de-escalation issues. Patient was not responding to conversations we were trying to have. Patient was irritable. Patient was hostile. Patient was saying things like, or patient said, quote, I will cut your effing head off and feed it to you on a plate for supper, or whatever it was. You can use colorful language if it's in a quote. I giggle every time I get to type cuss words in my chart.
Yeah, but your point is you're creating the environment, right?
Exactly. If QA pulls up that I chemically and physically restrained a patient, they pull that chart up and I have in my narrative, patient said these explicit things to me. Patient, showed physical aggression towards EMS crew. Patient was swinging at EMS crew. They are not going to question why I physically restrained and chemically restrained that patient. It is justified. right? But if I just say, yeah, I knocked him out with a night-night juice and I tied him on the stretcher and there's nothing in there giving me a good reason as to why I did it, that's a problem. Okay, so guys, just make sure everything is objective, everything is factual, and you're using that narrative to justify your actions. All right, whether it's inside protocol or outside protocol. If you call for online orders, make sure you document the name of the doctor, right? If you use any persuasive techniques, if we have anybody like on scene that we talk to, like a roommate or a significant other, anything like that, try to get a name.
How often are you going outside of protocol? Does it happen a lot, or?
Not a ton. And it's not like a ton of invasive stuff that happens outside of protocol, but it's like, hey, maybe can I give one more dose of this medication? Or, you know, a lot of the pediatric drugs that we give have to have medical direction approval. But yeah, it's not a lot, but it's not for big things. It's not for like, hey man, can I like crack this chest dude in the field? It's just like, hey, he's really, really hurting. This is a burn patient. I've already gone through all of my fentanyl. Can I give him, you know, one more dose type thing? Okay. Guys, hold on. I can't remember where the slide is. You're going to have to multitask on scene, right? You're going to have to keep track of approximate times, right? Especially when you took vital signs, when you gave a medication, when you did an intervention, because vital signs and medications, it's important to have the correct amount of time in between those different things. We'll talk about that in pharmacology. But just make sure if you're not actively sitting on scene, talking to your patient and doing patient care and documenting at the same time. You're providing solely patient care on scene, and then after you're done providing patient care, then you go back and document. All right, so you're going to have to remember this stuff. And if you're not good at remembering approximately what time or exactly what time you gave nitro, when did you give, you know, the oxygen, how much oxygen did you give, what was the dose of the nitro, you need to have a little notebook and write this stuff down. All right, we do have a kind of, not, I guess a cheat way. Let's see if we've got it in here. All right, so guys, we keep, we call it Grady tape on the truck. There's 1 inch and 2 inch tape. So if you don't want to like fool with getting a notebook out every time and writing it down, what you can do is for each call you get, have that right there. Get a new tape for every single call you run. So that way, when you get a blood pressure, all right, you can write down real quick 120/80. All right, you can write down nitro at 1202. You're not having to like reach in your pocket and write in a notebook. Then you can, when you're sitting down charting, you can be like, oh wait, what's that blood pressure? Oh yeah, 120/80. Okay, so if you're not good at multitasking, then I would go ahead and try the tape method. So that way, because guys, you might have a day where you get call after call after call after call, and you're that busy and you don't have downtime in between to chart. You don't go home, you don't clock out until all of your charts are done and submitted. So if you are at the end of the day, you're sitting in the ambulance bay, you guys are at headquarters, and you're like, dude, I gotta write 4 different charts. You can start to mix up, what was that guy's vital sign, or was that woman's vital sign? What was a medical complaint? Did I give that person nitro? You're gonna get them confused, okay? So just make sure you're keeping track, you're multitasking, you're keeping track of time, dosages, all that stuff, okay?
Quick question, Professor A, before you move.
1 second, I got one in class and then I'll come to you.
Okay.
Does that run the risk though of miscommunicating or misinterpretation?
No.
No, it's okay.
As long as you, like I said, you're interacting with that patient, you're providing patient care, you're not just having your notes like in a notebook the whole time, then you can just say, okay, you know, I'm just going to write this down real quick, because you can even joke, if I don't write it down, I'm going to forget it, like me. Like I told you guys, like email me or my they're my post-it notes. So as long as you are giving 90% of your attention to the patient, it's fine. All right, who's over here?
Yeah, I was wondering, with the keeping of the time situation outside of when we're taking vitals like the blood pressure and things like that, is that another reason why we require like the seconds on our watch, or is that just more just when
No,
we're doing vitals?
Seconds is going to be when you're obtaining a heart rate, when you're obtaining a respiratory rate. You just need to know hour and minutes when you're documenting.
Okay, I just wanted to make sure because I didn't know how in depth that was with the timestamps. Okay, cool.
No, just to the minute.
If there is a quote that you want to include in your report and you want to make sure that you don't forget it, can you write that down too? Or is that like?
I mean, you can if you have time, but just make sure you guys are doing like patient stated quotes, bystander stated quote, end quote type thing.
Are you,
Right.
question,
Huh?
Instructor A, are you allowed to, for example, voice record yourself while you're on a call just so you'll be able to accurately record things later?
You have to be careful with that. Sometimes you can do kind of like a dictation, but you need to let the patient know what you're doing if they're alert and conscious and say, hey, I'm saying these things so I can document them later. Because if it's any type of recording, whether it's visual or audio, the patient has to consent if they're going to be in that recording. Okay, does that answer your question?
Yeah.
All right, so guys, again, make sure you get the name of the person who you transfer that care over to in the emergency room, because if that patient, let's say that you send them out to the waiting room, Nurse Jones signs for that patient and they ended up like passing out and dying in the waiting room. That's not going to be your lawsuit. That's going to be Nurse Jones's lawsuit because she assumed the custody of that patient. All right, you guys need to know that if you do a paper report, if you make an error, there's no backspace button, right? So if you write something incorrectly or spell something incorrectly or whatever it is, if you write it out, put a one solid line through it and then put your initials in that top corner. Don't scribble it out like that. Don't, write little doodles through it. Just one solid line and initial that, hey, I'm acknowledging that I made this error and I'm correcting it type thing. If you do have to go back and do a paper report. Reporting errors. So again, in that video we watched yesterday, the court case, he made a mistake in his documentation. He charted that little boy who is obviously dead on scene was alert. What does alert mean?
You're alive.
That you are aware of your surroundings, right? He charted that because the little boy's eyes were open, but the patient was dead. So he realized what he did and he contacted QA because guys, once you submit these charts, they go to the QA universe. And once you lock them out, you don't have access to them anymore. All right, you've got to message QA and say, hey, I just remembered I didn't upload that attachment to that chart. Can you send it back to me? Okay, and every time QA sends something back to you and an amendment is made, it's notated. Whoever logs in to do it and what time it's done. So guys, just make sure you are triple checking your charts, making sure your timestamps are right, making sure everything's in order before you lock them and submit them, because you have to go through a process to get it back, okay? In any capacity, if possible, get a patient signature, get a witness signature, especially if it's an AMA refusal. Guys, if PD or fire was involved in the call, try to get the engine number of the fire department that was on scene. Like what station was there helping you out? Maybe not so much names for the fire department, but they can look up and say, okay, engine 11 was on scene. They can go back and say who was on shift on that day at that time.
You want to get badge numbers?
Try to get badge numbers from PD, especially if it's just like one PD officer that's involved. At least get a last name for PD officers. Okay, especially if your patient is in custody, we want to have that documented. So remember, guys, we are mandated reporters. If we have any type of like a dog bite, infectious diseases, any type of physical assault, abuse, anything like that, do remember, keep everything objective in your chart. We don't put suspected abuse case, contacted supervision. That doesn't go on your chart, just as long as you are making sure that that phone call is made, that conversation is had. Guys, you can even, when you get to the hospital and you give that verbal report to the nurse, you can let them know, hey, I think this is an abuse case. You need to get social services involved. That's sufficient for being a mandated reporter. Just make sure you have that nurse's name in your chart, because if that nurse doesn't do anything with that information, you can say, oh, no. I talked to Nurse Mary and I gave in my verbal report, I said this, I said that. Okay.
Yeah, but if you don't document it, doesn't just your word over.
Right, but we have to be careful. You can put something, maybe, informed Nurse Mary to involve social services in the case, because that's objective, that's factual. But you can't put that you're assuming, you're coming to a conclusion, it's your opinion that this is an abuse case in your chart, because that's subjective, it's not objective.
So do you look to get the sign that you reported it?
Talked about that. Guys, you guys can read into this. You can go through the official terminology. There are different kinds of radios that provide one-way traffic, two-way traffic. Some are mobile, some are stationary. Make sure you're going through and reading this in your book and in your notes, just so you know this information. I'm not going to take a ton of time to lecture on it. Most of the radios that we use are two-way radios. That means that I'm going to talk on the radio and I have to let go of my button before somebody else can talk. We can't talk at the same time. All right, so again, that's important to understand. You're identifying, hey, this is so-and-so, I'm trying to talk to so-and-so, and then make sure that, you let go of your button, you receive that information. That's how the two-way radios work. You can't talk at the same time like you can on like a cell phone. Always try to use the radio as a form of communication, because again, it's recorded. So if anything ever comes of it, you can be like, no, pull a tape. I talked to this doctor, he gave me the order for that, and I did it over the radio, so it's recorded. There's no discretion there. Do we use what?
You said you use the radio to call a doctor, or do you call them?
You can utilize the radio to call a doctor to get like online orders, or you can use a cell phone. But again, remember that the radio is the only one that's recorded. Typically it is for security purposes, but it takes them longer for whatever reason to get, because there's only one radio like at the nurse's station, and then they have to go like to that particular nurse's station versus like just picking up a phone type thing. Again, guys, just know these definitions: repeater, trunking system, all of that. We do have the technology that if you get a 12 lead, you take a picture of somebody's heart, because that's within your scope to obtain a 12 lead, to get that picture. We can transmit it. We can send it off to the hospital. All right, we can send it off, and then we can call Grady or get Grady on the radio and be like, hey, I am crew so-and-so. I just sent over a 12 lead. Can I get the attending on the phone to tell me what's going on with that 12 lead? All right, that's totally within our technology and within your scope, and we'll talk about that when we get to cardiac emergencies. Know what a satellite phone is? Simplex, duplex, multiplex. Because these are just definitions you need to know. It doesn't so much affect the way you provide patient care, so I'm not going to spend a ton of time talking about it, but you need to know the stuff for the test. Trunking systems. The FCC also know that because everything is recorded over the radio, the FCC monitors it because it is available to the public. Right? You can get the scanner app on your phone, or if you have a scanner at home, you can tune in to the state of Atlanta. All right? You cannot curse over the radio. You cannot use any slang term over the radio. If the FCC picks up on that and is monitoring it, it is thousands of dollars of fines to Grady. All right. I've worked with someone who was not aware of that one time and dropped the F-bomb a couple times on the radio. And then supervision immediately chimed in, Unit 622, cease radio traffic and give me a landline. Like, call me right now. Pretty much told him, hey, dude, shut up. You can't say that stuff on the radio. All right. So don't cuss. Don't use any, I mean, not that you guys would, like slang or any just inappropriate verbiage on the radio, because everyone's listening.
Does slang include like colloquial language, like southern words like howdy and such?
No, not really. Anything that can come across as offensive. All right, so again, guys, just dispatching. We talked about this yesterday. They are talking to whoever's calling in. All the information that they are giving that dispatcher, it comes through on a computer in your truck. Everything that the caller is telling, all the questions that the EMD, that emergency medical dispatcher, is asking, all that information is coming over. We have a really cool system. It'll pop up on the screen, the address, and we can click how many times we've been there. On what date did we go there? What did we go there for? Did we transport? Was it an emergency? Was it not an emergency? So we can have maybe an anticipation of, you know, is this a loyal Grady customer? Is this someone who's never called 911 before? We get a lot of information from dispatch, because dispatch helps start our what?
Assessment.
Not assessment. First thing we do when it comes to our scene. Our scene size up, right? They're gathering how many patients do we have? What type of call is this? Is this a gunshot wound? If it is, you know, is the assailant still on scene? Is APD en route? Have they cleared the scene? Is our scene safe? Is the person having difficulty breathing? Are they turning blue? You know, is CPR in progress? Is this a cardiac arrest? All of this information is coming through dispatch. Again, when we get on scene, we want to confirm that this information is correct, right? Guys, I can't tell you how many times we get dispatched to a cardiac arrest and we get on scene and the person's sitting up right like, no, I'm breathing. I just called you because I have chest pain. Okay. And it's not always a dispatcher's fault. It can be because the information they're giving us is only as good as what that caller is giving them, right? So we want to make sure we don't get tunnel vision with that dispatch code, because it could be something completely different. All right. It could come out as a headache, that the patient's completely alert, that this is a code 3, which means we're not going lights and sirens. It's not a life-threatening emergency, but we get on scene and it's a cardiac arrest. That's happened a couple times with me. It comes out as a non-emergent call. We get there and I'm like, oh crap. All right. So don't get tunnel vision. Do your own assessment, do your own scene size up when you get there to make sure we have the additional resources. Make sure you're bringing your equipment to all of these calls, because if you're like, oh, this is just a headache, I don't need the cardiac monitor, I don't need this, and you just stroll in with you and your Jesus hands and the patient's in cardiac arrest, well, we just wasted 3 minutes having to run back to the truck and get our stuff, right? So don't assume that that triage that dispatch gives you is always going to be correct, okay? We talked about that. We can watch this video, guys. It's just a radio report like I gave you an example of.
This is a demonstration of a hospital radio report, which we give when transferring the patient. Anything in your hospital radio report you're going to need are your unit and the capabilities, your patient age and gender, the chief complaint, findings, vitals and conventions, and PTA for the facility. So this will be an example of what a hospital report would sound like. You're on an age. This is BLS ambulance 22. You're on an BLS 22. We're en route to your facility with a 34-year-old male complaining of 9 out of 10 chest pain. His vitals are BP 140 over 98, pulse 96, 6, respiration 20, feebly active, lung sounds clear. We've administered 3 81mg tablets of aspirin and had the patient on 8 liters of O2 via non-breather. We'll be at your facility in 5 minutes. And that's an example of the hospital ready report.
Okay, that didn't take long at all. We had the meat and potatoes. Guys, sometimes if that dispatcher, or not the dispatcher, well, whoever's taking report, they might ask some clarifying information. But guys, just keep it short and simple. And the verbal report can be longer. Is everyone clear on what medical control does? How they serve, what we utilize them for? Everyone's good with that? You Zoomers okay with medical control? Okay. Guys, make sure you have a full battery when it comes to your radio when you go in service. That's part of your equipment that you guys need to check. If your battery starts kind of beeping at you saying that it's dying, that's a vital piece of equipment, right? You need to get in touch with supervision. Sometimes they have battery exchange stations at the hospital, but just make sure that you've got a fully charged battery at all times, because that's going to be your lifeline, right? If you go on scene and your scene starts to become unsafe and you need APD there immediately, your life is in danger. If you don't have a radio, how are you going to communicate that? Okay, make sure your battery is always charged. Questions, comments, concerns. Guys, I don't go through these review questions at the end. It takes a lot of time, but they are on the PowerPoints on the Google Drive if you want to go through them for kind of like a review. But I don't go through them during lecture. Everybody good? Everybody over there good?